Timur, for your introduction and for the opportunity to present the endometrium-free closure technique, its history and resurrection. The focus of today's presentation is on the anatomy of the uterine wall and its treatment during hysterectomy closure. My specific challenge and my question are, should the surgeon pay attention to the following structures: the endometrium, the endomyometrial junction, and the myometrium before planning for the closure of the incision? Another challenging question is, how can a random, all-layer inclusive closure impact niche formation and long-lasting clinical complications? My talk, in essence, is an answer to the previously posed question about the technique used during hysterectomy closure. My experience is that the endometrial-free closure technique can avoid niche formation, thereby lowering the formation of cesarean scar pregnancy, the ensuing placenta equida spectrum, and other related disorders. I'm introducing a tool to survey the surgical site or the operating field to better understand the pathophysiology of long-term post-cesarean complications, as well as to gain novel insight from tissue magnification and video recording. This is an advanced optical recording system which promises to bring clarity to the post-cesarean delivery complication conundrum. I am using an exoscope or telescope as a magnification tool during cesarean section. The surgical steps are in plain magnified view. It enhances visualization of surgical anatomy, captures important details of the surgery. It documents verifiable techniques for comparative analysis. More importantly, it is a useful tool for longitudinal research, for teaching, and to evaluate outcomes. Using the tool, here is the relevant uterine wall anatomy. You could clearly see the myometrium, the endomyometrial junction, the edges of the endometrium, the surface of the endometrium. We've learned from the tools that there are various textures of endometrium and myometrium. The endomyometrial junction is clearly visible, and the myometrium is clearly distinct from the endometrium. Now, before addressing the main subject of the endometrial-free closure technique, I would like to present the most relevant historical background leading to it. Here is the story of cesarean section. In 1882, Max Sanger introduced the conservative cesarean section. In 1896, Hermann Pfannenstiel described the sharp abdominal incision. In 1921, Monroe Kerr published on the lower uterine segment incision. After the above innovation by these pioneers, a new era of surgical technique started with Sidney Joel Cohen in 1953 describing the blunt abdominal incision, Michael Stark popularizing in 1983 the Misgav-Ladach method, and in 1981, I started to resurrect endometrial exclusion and publish it as the endometrial-free closure technique in 2020. The conservative cesarean section by Max Sanger, including a closure technique which consisted of two layers. The first layer consists of interrupted deep sutures through the thickness of the myometrium, cautiously avoiding the decidua, and a second superficial myometrial layer, which included the serosa. The technique to avoid the decidua originated over 140 years ago and became the standard for the classical cesarean section today. Here you could see the decidua, the myometrium, the uterine cavity, and the first layer suture above the decidua. The second layer captures the remaining myometrium for a complete closure of the incision. In 1921, the lower uterine segment incision closure was debated, and for over 100 years, the subject of layer closure has been of concern. In 1921, Monroe Carroll wrote, "Another very important question is whether the uterine wound should be stitched in layers or with through and through sutures." 5 years later, he published the technique of cesarean section with special reference to the lower uterine segment incision. In his description, he stated the mucous membranes with the innermost portion of the muscle coat is now sutured with a continuous number 1 chronic catgut suture. The edges of the mucous membrane, referring to the decidua, being directed inwards toward the uterine cavity. He further refined the method, winning international acceptance as the standard procedure for the lower uterine transverse incision as we know it today. Here is his original illustration. The time between 1920 and 1970 became the era of endometrium or decidual sparing. Cesarean section, as well as a trial of labor after lower segment uterine incision, became safer. Sparing the endometrium during closure had been passed on from obstetricians to residents and practiced well until the 1970s. Many are still using it nowadays. In this brief historical review of techniques, I emphasize the contemporaneous importance of layer approximation, as well as the exclusion of endometrium decidua into the uterine closure. However, after that period, a change occurred. In 1954, Sidney Joel Cohen introduced an incision for abdominal hysterectomy that relied more heavily on blunt dissection as opposed to the traditional sharp phalangeal incision. And in 1983, Michael Stark introduced the Misgav-Ladach method, named after the hospital in Jerusalem where the method has evolved. Here are the essentials of the Misgav-Ladach method. Using the Joel Cohen abdominal blunt incision, it uses also finger blunt stretching of the uterine wall after a small transverse incision in the lower segment. 1 layer repair of the incision using a continuous lock stitch on a large needle, and it emphasizes to take big enough bites from the lower to the upper edge to get secure hemostasis. This, in essence, phased out, sparing the endometrium. Now, there are numerous articles in the literature, hundreds of them, that discuss the Misgav-Ladach versus financial care incision. Here are a few examples. However, nowadays, this Dalkey article is the most influential one on the subject of cesarean delivery technique. It was published in 2020. Here are the claimed advantages of the Misgav-Ladach technique. In non-randomized trial, it is less traumatic for the mother. The post-operative recovery is quicker. There are less febrile reactions and need for antibiotics. There is a quicker return to normal bowel function, less peritoneal adhesions and less scarring in the abdominal layers. There's less bleeding in the abdominal wall. It can be used for both planned and emergency sections, and the method is easy to learn. It further states that cost and time saving are very important claims. These are short-term benefits of this method. However, there have been warnings from many authors that there are unknown long-term consequences of closure techniques. To that effect, Dodd et al. studied 27 randomized trials of 1,800 CDs. They concluded that for many techniques, short-term maternal outcomes are equivalent, and warned that until long-term health effects are known, surgeons should pause and continue to use techniques they prefer and currently use. Now, these then unknown consequences are now known as cesarean scar disorders.